Hello, my name is Spencer Wilhelm. I am a medical student at Rocky Vista University. Actually, just matched into family medicine up at Boise Full Circle Health. Super excited about that. And I'll be talking about colon cancer screening today. So to start off with this, I wanted to talk about a case. This is a pretty standard case. I've seen this several times with people throughout the last couple of years. So this is a Mr. Glenn Sturgis. He's a 57-year-old male who's presenting to the clinic after his father died from colon cancer at age 75. Glenn is worried about his risk for colon cancer and wants to know what he can do to decrease his risk and to see if he potentially has it. Glenn doesn't have any symptoms right now. He hasn't seen any blood in his stool. He hasn't had any screenings done before. It's been years since he's seen a doctor, actually. And no constitutional symptoms like fevers, chills, nighttime sweats, fatigue, weight changes, stool changes, or urinary changes. So Glenn's past medical history is significant for high blood pressure. It's been high on several occasions in the past, but he's never received medications for it. He is obese. He has poor outpatient follow-up. Other than that, he thinks he's a fairly healthy individual. His social history is significant for living with his wife. He works at a store, and his family history is significant for a mother who has high blood pressure and a father who died of colon cancer at age 75. He doesn't know the specifics behind it. He just knows that his dad had died of colon cancer. On physical exam, his blood pressure is elevated. The rest of his vitals are fine. Well-appearing male, cardiovascular and pulmonary exam are both normal and non-significant. On abdominal exam, he has a convex obese abdomen. He doesn't notice any rashes. There's no masses palpated, and he's non-tender in all four quadrants. No organomegaly is noted. He decided he didn't want to perform a rectal exam today. The rest of his exam was fairly unremarkable. So for Glenn, what's the next step? So taking a step off to the side, as a medical student, sometimes it's hard for us to know exactly what our patient in front of us needs, partly because sometimes the EMR isn't very advanced and it doesn't have flagging systems to help you know when you're supposed to start certain screenings. But also, sometimes you just don't have access. So I'll share with you a tool that I use a lot as I've been a medical student, and especially at the beginning, because it really helps you kind of drill into your mind the different screenings that you need to use. So this is an app called the USPSTF Preventative Task Force app. You can type in your patient's credentials here. I'm putting in Glenn's information. Glenn has never used tobacco. He is sexually active, but he's been monogamous. This is all the recommendations for a patient like Glenn. And you can separate it into each of the different categories. We'll focus on the A and B, and as you go down, you can see all the stuff that we could do for Glenn today. We won't address all of them, like HIV, hepatitis screenings. We screen for his blood pressure, and we'll probably screen for diabetes. But let's focus on colorectal cancer. Here they say at age 50, but then you scroll down and it says age 45. That is a recent change over the past couple of years. And then it also talks about all the different screening strategies that you can use and some risk factors down there at the bottom. So we'll get into a little bit more of all of this throughout the rest of the presentation, but I just wanted to make you aware of this tool. It can be very helpful for you. So quickly, for an assessment and plan for Mr. Glenn, this is going to be a fairly bare bones assessment and plan for him. There's a lot more that we could do. As you saw, there was tons of things on his preventative health care that we could do. But as to not overwhelm a gentleman who hasn't been to a doctor in a long time, we'll just stick with the basics for now. So we want to address his high blood pressure. I would like to have him come back in 2 weeks, as doesn't sound like he's ever been officially diagnosed. His blood pressure has just been elevated in the past. So we'll have him come back in 2 weeks and see where it's at. At that point, we consider starting a starting dose of lisinopril. And then with his obesity, we're going to refer him to a nutritionist, but that also puts him at risk for hypercholesterolemia, hyperlipidemia, diabetes, and some other complications that can be related to the blood pressure as well, such as kidney failure. So that's why we're going to do the CMP. And then the colon cancer screening, we are going to do a colonoscopy with Glenn. And there are many other options that you can do with your patients, but that's what we decided. And I'll talk about all the different methods you can use. And last of all, and we'll talk about things that Glenn can possibly do to help lower his risk of colon cancer. And that'll be on one of our last slides, but I just wanted to mention it here as well. So getting into colon cancer itself, why do we screen for colorectal cancer? So colorectal cancer is the third most common cancer, both by incidence and by mortality. So you can see in the diagram that we have here, you have breast, prostate, lung, and colorectal cancer. So it's the third most common causes in male and female. Males, it's a little bit higher. It's about 33% higher than females. In the United States, we have about 153,000 new cases every year of colorectal cancer, along with 46,000 deaths. As your age increases, your risk for developing colorectal cancer will also increase. So it has a fairly large disease burden on the healthcare system within the United States. And the earlier you catch it, the better prognosis you're going to have. Whereas if it's much later stage and it's already spread to other parts of the body, it can be pretty difficult. So this is getting a little bit more into the incidence by age, and this graph helps, at least it helps me visualize why we've changed the screening age from 50 down to age 45. And we'll talk about it later, but for some people it'll even be down to age 40 or earlier. So there's going to be two arrows that pop up between ages 40 and 50. You can see there's a rapid increase in the incident rate of newly diagnosed colon cancers. So we start at age 45 because this is the age where it's really starting to ramp up, where we're starting to see it a lot more in the population. So that's why it's moved down there to age 45. The NCCN guidelines, this will encompass a little bit of the next few slides. As far as screening for individuals, they recommend categorizing people based on their risk factors. An average risked individual is healthy, they don't have any family history of colon cancer, and they don't really have any comorbidities that can contribute to colorectal cancer. Then you have the increased risk group. Those are people with a family history of colorectal cancer, who have a history themselves of colorectal cancer or advanced polyps. Or if they have ulcerative colitis or Crohn's disease, these can also predispose you to a younger age of colon cancer. And then the high-risk individuals are those with hereditary syndromes such as Lynch syndrome or polyposis syndromes. And then a few of the other risk factors, just to touch bases on these, aren't considered major risk factors, but they can increase your risk for colon cancer. Having high-fat diet, basically poor diet, low exercise, obesity, and tobacco use and alcohol. As far as the benefits for screening, as we have in the United States, as we have increased our screening rates from 1987 all the way up to the early 2010s, we have seen a pretty drastic change in the amount of advanced colorectal cancer that we're seeing. So this number is the advanced colorectal cancer that we see. It's gone from 118 to 74 cases per 100,000 within the population. So that's a pretty decent change in the incidence rate. And overall, cancer diagnoses have gone down between 1 and 2% over the past 10 years or so. And a lot of that has to do with the increased screenings that we have issued within our healthcare system. The other benefits of screening is we can remove these precancerous polyps before they become cancerous. Almost all colorectal cancers will start off as a polyp, but not all polyps turn into colorectal cancer, if that makes sense. And then for those that do have colorectal cancer screening on their screening, hopefully we can get it via an early detection before it's spread very much, and then all we have to do is resect that one segment, and their prognosis will be much better. So getting into the different groups and when you would start screening individuals, these are fairly new guidelines over the past couple of years. It used to be at age 50, as I mentioned before. Now for a healthy population, that's age 45. So for individuals who have a family history with a first degree relative that has colorectal cancer, so that's your mother, father, any of your siblings, or your children. If any of those have colorectal cancer, you'll start screening at age 40 or 10 years before they were diagnosed with their cancer. So for example, if they were diagnosed at age 45, you would want to start screening at age 35 instead of 40. You go with whichever one's earliest. And then you'll rescreen every 5 years. So then if you have a relative that is a second or third degree, that doesn't increase your risk too much. It's definitely something that you should keep an eye on as a practitioner, because you know that they could potentially have a family inheritance going on. Like for example, in my family, my grandfather had colorectal cancer, but neither of my parents, siblings, or children have it. So I would get screenings at age 45, but if anyone had developed colon cancer, I would then start getting screened at age 40. And then last of all, this one's very similar to the first one, is a first degree relative with an advanced adenoma or a high risk polyp. Screenings are essentially the same for that age group as the first group I mentioned. So say you got screened with a colonoscopy and you found some polyps. This is something that not all practitioners, especially in the primary care field, are going to have to deal with. A lot of this will be for those that are performing colonoscopies, such as general surgeons, gastroenterologists, and even some family docs do colonoscopies as well. This is for them, and I'm including it for you just so that you can have this as a resource and for completeness. But essentially, the more advanced the polyp, the shorter the amount of time is going to be for you to come back for follow-up colonoscopies, or the more lesions that you have. So as far as screening options, there are essentially two types. We have stool-based screenings as well as direct visualization. Stool-based, you have the high sensitivity fecal occult blood test that you have to get done every year. The FIT test, which is an antigen test, you get done every year. Or you can do a DNA FIT test that can stretch out all the way out to 3 years. The one that I'm most familiar with that is Cologuard. And then for the direct visualizations, you have CT colonography, flexible sigmoidoscopy, and the colonoscopy. Honestly, the prep for all three of those is going to be fairly similar and uncomfortable. Most people say the worst part of a colonoscopy is the prep, and a lot of these you'll have to do that for anyway. So I would just say go for the colonoscopy, as that is the gold standard. And you can remove polyps at the same time if there are there. So as a note, if any of the stools are positive, the CT's positive, or the flexible sigmoidoscopy, that automatically puts it to where you're going to have to come in for a colonoscopy. That way they can remove polyps, or if there is any potential cancerous lesions, it can be diagnosed and it can be referred to surgery for rapid treatment. As far as the sensitivity for each of these tests, they all do a decent job at sensitivity for colorectal cancer itself. The colonoscopy is the highest, and that's the blue bar on each of these different categories. But where all of the stool testing and the CTs, they don't do nearly as well as the colonoscopy when it comes to sensing precancerous lesions. So those are the adenomas before they have turned into colon cancer or colorectal cancer. So that's just something to keep in mind as you're talking to patients and trying to educate them on these different tests that we could be doing for them. It's important to also understand that these are your patient's decisions as well. So besides the screenings and potential detecting colorectal cancer or precancerous lesions, what are some things that we can do now? So for Glenn, this is what I was mentioning earlier. There are certain things that you can do to help decrease your risk of colorectal cancer. Taking an aspirin, they say taking a daily aspirin for 5 to 10 years can decrease your risk of colorectal cancer. Eating healthy with high fibrous, low-fat diets, limiting your alcohol intake, exercising, vitamin D, so that could either be from having good amount of sunlight or from supplementation if needed, having healthy BMI, and quit smoking. So these are all things that you can have your patients do today, essentially. And last of all is shared decision making. I put this slide in here because it's really important that we help our patients understand this topic, because sometimes it can be a fairly sensitive thing for some individuals, or they can be embarrassed by the process of getting a colonoscopy or having screenings done. So it's important that we help them understand why we're doing this and helping them understand the different options that are available to them. A lot of people think colorectal cancer screening, oh man, I'm going to have to get a colonoscopy. But in reality, there are other options out there. And sometimes you'll have to make recommendations for a patient to do a colonoscopy versus something else based on their risks and family history and whatnot. So that's important to make those recommendations to your patients when appropriate. And last of all is respecting your patient's limitations. Could be something as simple as like a scheduling error or scheduling issue. But they could also have past traumas. I've had at least 2 patients in the last couple of years where this has come up, where they have had past history of sexual abuse, and the idea of a colonoscopy was very scary to them. So we were able to offer them these other options and help them understand the importance of this, and help them walk through this process. And they were able to get their screenings done. So that's all I have. These are some of the resources that I used. Thank you so much for watching, and I hope it was helpful.